Hello, I'm Jessica Polikoff, and today I'll be discussing a case of a rectal neuroendocrine tumor with hepatic and suspected osseous metastasis. The incidence of neuroendocrine tumors, or NETs, which are rare neoplasms of neuroendocrine cells, is rising in the United States. Low-grade and localized rectal NETs are associated with an indolent clinical course and a good prognosis. However, tumor metastasis can cause significant morbidity and mortality. We aim to educate physicians and trainees on the clinical and pathologic features of NETs for early recognition and management of this rare neoplasm. A 39-year-old woman presented to our hospital with abdominal pain, postprandial bloating, nausea, and constipation for 1 month. She did not have any past medical history aside from moderate alcohol use. She had intermittent low-grade fevers for 3 months and a weight loss of 2 kilograms over the last month. On exam, there was tenderness of the abdominal right upper quadrant. She was afebrile and normotensive at the time of admission. Laboratory findings included a mildly elevated AST of 72 and a normal ALT. She also had a microcytic anemia and a thrombocytosis with a platelet count of 558,000. Serologic testing for hepatitis B and C was negative, and alpha-fetoprotein level was normal. Abdominal ultrasound revealed an enlarged liver with microlobulated contour and multiple masses. We then performed abdominal MRI, which showed multiple hypointense masses in the right and left hepatic lobes on T1 weighted imaging, as seen in Figure 1. The largest mass, located in the left lobe, measured 12 by 15 centimeters. Our differential at this time included cirrhosis with hepatocellular carcinoma versus metastatic disease. Due to findings of sclerotic bone lesions of the axial skeleton on abdominal CT, we also performed a technetium bone scintigraph, as seen in Figure 2. This revealed multifocal uptake throughout the thoracic spine, right sacrum, and left proximal femur, concerning for osseous metastatic disease. The patient underwent colonoscopy, which revealed a 1 centimeter smooth, broad-based rectal mass. Cold forceps biopsy was taken. Core needle biopsy was also performed on a left liver lobe lesion. On immunohistochemical analysis, there was strong positivity for CD56 and synaptophysin stains within the tumor cells. Chromogranin A marker was negative. The Ki-67 proliferative index, which reflects cell proliferation, was 3%. The patient was diagnosed with a well-differentiated NET with hepatic metastasis. She was later discharged with outpatient referral to oncology, but unfortunately was lost to follow-up. The World Health Organization classifies NETs based on histologic differentiation and proliferative grading. Low-grade NETs are well differentiated and have decreased mitotic activity and Ki-67 index compared with high-grade NETs. The clinical presentation of colorectal NETs includes rectal bleeding and changes in stool caliber and consistency, though most patients are asymptomatic. Hepatic metastasis may cause abdominal pain and jaundice, whereas osseous metastasis may result in bone pain and pathologic fracture. Identification of NETs is most often made during screening endoscopy or incidentally on imaging for an unrelated complaint. On endoscopy, rectal NETs often appear as a single, smooth, submucosal polypoid mass. Diagnostic confirmation is made by sampling biopsy and histopathologic analysis. Immunohistochemical staining of neuroendocrine cells may reveal positivity for chromogranin A, synaptophysin, and/or neural cell adhesion molecule, also known as CD56. Treatment of localized low-grade rectal NETs with endoscopic resection results in a favorable prognosis. In the case of metastatic disease, management involves radical surgery and systemic therapy. However, morbidity and mortality largely increases. In conclusion, the clinical course of low-grade NETs is relatively indolent with a good prognosis. However, these neoplasms may become more aggressive as they transform over time. We emphasize that early diagnosis and management of NETs prior to metastatic spread is essential for superior outcomes. Thank you for listening today.